Dana Miller presents Over-the-Counter Analgesics, Who, What, Which, and How Much, featuring Paul Christo, MD, and Blaine Carmichael, PA, discussing over-the-counter counseling, putting it together. Now here is Dr. Paul Christo.
The opioid epidemic has led the CDC to publish guidelines emphasizing non-opioid treatments for chronic pain. This has inspired other institutions to establish similar recommendations on limits for opioid medications. For example, Medicare will limit opioid prescriptions to 90 morphine milligram equivalents per day in 2019, and CVS Pharmacy is now requiring immediate release opioids before extended release opioids and limiting the daily dose. In this series of podcasts, we've discussed Nsaids as a non-opioid treatment for pain. They can be very effective for acute pain like strains, sprains, post-operative pain, osteoarthritis, headaches, muscular pain, and even metastatic bone cancer. This is probably why they're the most widely used analgesic medications worldwide. I'm here now with Blaine Carmichael, physician assistant. Before we get into treating patients in pain with over-the-counter analgesics, Blaine, talk to us about your role in managing patients with pain.
My role mostly is to take care of primary care setting with a patient who comes in complaining of low back pain or a sprained ankle or they've got a headache. And my role is to determine what's the etiology of their pain. Is this acute pain or is it evolving into chronic pain? How they treated it before? And evaluate the general overall health of the patient to help me decide how I want to treat and evaluate the pain.
How often do you use non-steroidal anti-inflammatory drugs in your practice?
Very frequently. I would say at least half of my patients at one time or another are on a Nsaids or a Acetaminophen, some sort of analgesia that is not opioid.
Mm-hmm. Do you find that you're using them for patients who have more acute pain or also chronic pain?
Initially, it's acute pain for my younger patients. The older patients, generally, they will be arthritic or recurrent low back pain. Say, give a try of this. Let me know how that works. And we'll exchange information through our portal, and they can email me. We get back and forth.
Yeah, that's handy. Well, as a matter of fact, have you found that certain Nsaids seem to be more effective as a pain reliever than others?
Yes, but it sort of depends on the patient, too. Sometimes it'll be just fine with ibuprofen, and they'll get a good relief. Others will tell me, it doesn't do anything for me, so then I might add some acetaminophen to that, or maybe even change to naproxen, but I don't like using the longer-acting Nsaids very often, or maybe even a different brand. Believe it or not, sometimes I even use aspirin and get fairly good results.
Mm-hmm. I've found, too, that when I combine acetaminophen with a different NSAID like ibuprofen, especially for post-operative pain or for acute pain conditions, that patients report even better relief than just with one compared to just one alone.
Absolutely, I agree with that.
Have you noticed also with the advent of the CDC recommendations that patients that are sent to you from surgeons have fewer opioids available? That is maybe just 5 or 7 days compared to a month's worth of short-acting opioids for their post-operative pain.
Yes, sometimes it depends on what the surgical procedure is, but I know CVS and Walgreens and different pharmacies won't give them more than about 7 days without having to get a new script or a new triplicate.
And I've had patients say to me, well, boy, I'm not really sure that just a week's worth of opioids is going to treat my pain. What happens if the pain escalates? What happens if the pain doesn't go away and I don't have any more opioids left? What do you do in that circumstance?
I tell them that, I'm your safety catch. I can help you with that. If you're having more pain than you are expected to have, you let me know and I can get you onto some other analgesia, which will probably help. And then I generally will talk to them about acetaminophen and ibuprofen and how to start that. Yeah.
Let's talk about the mechanism of action of Nsaids. I've had patients say to me, Dr. Christo, how does this thing actually work? It does seem to work. It reduces my pain. Tell me about the mechanism of action.
Well, as I understand it, it reduces the prostaglandins by either blocking the COX-1 or the COX-2, depending on which NSAID you're using. And that can lead to problems in the stomach as well, with some NSAIDs, because the prostaglandins tend to protect the stomach. And so you might have to switch over to a COX-2 inhibitor, like celecoxib, one of those. I don't even know if that's available over the counter these days.
What I like, too, about the NSAIDs is that they have, in my mind, 3 different mechanisms of action. That is, they're good fever reducers,
Yes.
so they're antipyretics, they're anti-inflammatories, and they're analgesics.
Correct. I'm aware of that. I do explain that to my patients at times. Now, the acetaminophen, very low anti-inflammatory, but at higher doses it does have some, and it seems to work pretty well in some of my arthritic patients.
Yeah, that's a great point.
Yeah.
Well, you brought up acetaminophen earlier. I found that when I use acetaminophen, that patients with osteoarthritis or rheumatoid arthritis will say, yeah, it helps maybe 30%, but I really can't get much more relief than that from acetaminophen compared to the other NSAIDs like ibuprofen or meloxicam, as you mentioned, or celecoxib. What's your experience?
I agree with that. I think it depends on what the problem, what is the source of the patient's pain. If it's a mild little headache, the Tylenol extra strength or whatever is available may take care of that. But if it's a big old migraine, then they may need something a little more fierce, like 800 milligrams of ibuprofen and maybe 500 of Tylenol mixture to get effect. But the Tylenol, I think, is in general a little milder analgesic than the Nsaids are. Yeah. In my experience. But when you combine them, then you get a good response. Now, there's a pediatric issue that you got to think about when you're combining those two, in that, you can, if you're treating pyrexia with Tylenol and you're not getting where you want, and you want to add that NSAID to that, like ibuprofen pediatrics, which maybe in pain medicine we don't see a lot of, but in primary care, I see cradle to grave and everything in between. So you can't give both of them at the same time 4 times a day, because then you'll get them overdosed on the acetaminophen. So you got to be careful with that. So I like to treat TID for the ibuprofen and keep a good watch on the Tylenol so that we don't get them overdosed. And of course, then everybody has to know about Rye syndrome. You can't give aspirin to kids, but it's an NSAID that's out there, and sometimes it'll be in the parents' cabinet, and they'll say, "Oh, this is for fever. Let me give it to my kid." And then so that's a caution I give all the moms when they come in with their kids with an earache.
Yeah, those are great points. Let's talk about the COX-2 inhibitor, celecoxib or Celebrex. When do you typically use Celebrex in your practice?
I like to use it when somebody has a history of peptic ulcer disease or just can't tolerate ibuprofen or naproxen, naproxen. It's a little more expensive, and then sometimes I'll get a pre-auth requirement that takes a couple of days to get it, and they don't sample it anymore. So you got to think about that. So I may just temporize for a while and give them a ibuprofen and have them take an H2 blocker or something to go along with it. So Celebrex is a great drug, and I've used it a lot over the years. It's a little bit longer acting, but it does protect the stomach. Sometimes people get confused and think, well, you can use Celebrex in people who have chronic kidney disease. Well, you really shouldn't, because it doesn't have the same protective effect on the renal system as it does on the stomach.
That's an excellent point, and I'm glad you brought that up, because regardless of whether it's a COX-2 inhibitor or not, or that is a traditional NSAID, there can be the same side effect profile on the kidneys.
Correct. So I do watch for chronic kidney disease, and the older we get, more likely you're going to have a creatinine that's rising, and if they're chronic kidney disease 1 or 2, you can still think about that. It's going to slow the renal blood supply down a little bit, but if you keep an eye on it and they're in pain, you got to worry about quality of life things too. Some of these old guys who have been carpenters and masons and things, they have a ton of arthritis, and they don't want to be sitting at home in their easy chair watching TV all day.
When you mentioned watching them, that is patients who or older adults maybe who are on celecoxib, that is watching their renal function. How do you do that? What are you doing to watch their renal function and even blood pressure?
Most of these older folks already have hypertension or diabetes, and they're measuring their own blood pressures. I'll just have them send me a little text about their blood pressures, once a week or so, and my nurse will review that, and she'll let me know, hey, Mr. Smith's pressure is going up. But I'll bring them in fairly often, too. If they've got diabetes, hypertension, chronic kidney disease, I want to check their lights. I want to check their B and creatinine. And I personally just want to talk to them. And I want to look at their peripheral vascular system. I want to get my own blood pressure on them and, just kind of watch them a little closer.
Have you found, with respect to celecoxib or Celebrex, have you found that patients actually do report less or fewer GI symptoms like dyspepsia, for example, or stomach upset with that particular COX-2 inhibitor compared to the traditional Nsaids?
Yes, absolutely. I do see that. They're happier with that medication, but they're not happier with the little bit more cost associated with it. So we have to talk about quality of life with them, and it's available, I think, generically, and it's not near as expensive as it used to be.
Yeah.
So they do report that they get good relief with it and that their stomach symptoms are gone. But, I can kind of, with ibuprofen, I can add an H2 or a PPI and kind of get the same result. But now they're taking 2 medications instead of 1, and they're taking it more often than once a day. So, it's easier to remember once a day medication, and celecoxib meets that goal. Yeah.
Definitely. When do you then introduce an H2 blocker or a proton pump inhibitor? I mean, at what point? If a patient, for example, has been taking an NSAID for 6 weeks, 2 months, how do you make that decision?
Depends on their age and comorbidities. I will, if they already are on omeprazole or one of those PPIs, then I just remind them to continue taking it. If, on the other hand, it's a 35-year-old male with, recurring hip or elbow or wrist pain, neck pain because they've been in a car wreck or whatever, then after about a month, I'm getting them back in and I'm asking them how they're feeling and checking how's your appetite? Is your appetite going down?
Yeah.
I worry about them developing a little gastritis or irritated stomach. Then at that point, I'll generally offer a PPI to them.
Let's talk about side effects of the Nsaids.
Okay.
When you see a patient in whom you're going to start an Nsaid, what do you discuss with them in terms of the side effect profile?
Well, I remind them that most people get the effect of the medicine, and most people don't get the side effects of the medicine. I talk about, how studies are done a little bit to kind of give them some reassurance. And then I mention to them, but it is possible that you could develop some elevation in your blood pressure by a few points, so we want to watch that. It's possible that you could get a bleeding ulcer or gastritis, and so we want to know how that's going on with them. How's their stomach doing? It can affect some of their electrolytes, so I let them know I want to check their sugar. I want to check the potassium particularly, and so I'll start out with, if I don't have a CMP on board, I'll get that because I want to check liver functions as well.
What about bleeding?
I think about that, and if they're It kind of depends on their age. If it's a young person, I'll mention to them you might get easier bruising. If they're older, I'll mention that this can delay platelet aggregation. You can get bruising. You can maybe even get some bleeding in your stool you want to watch for. So we've got a whole gamut of things to discuss. So I do tell them this is not a totally benign medication. It's inexpensive. It can cause you some problems. Just let them know that's something we want to watch and that they should be aware that they're usually not too dangerous, but they can be, and this is what can happen to you.
Yes, I think those are great recommendations. I want to mention the 2 black box warnings that exist for Nsaids, though. One of them is that they can increase the risk of serious and potentially fatal cardiovascular thromboembolic events, including MI and stroke. And 2, all Nsaids contain another black box warning related to the increased risk of serious and potentially fatal gastrointestinal adverse effects, including bleeding, ulcer, stomach or intestinal perforation. Have you seen any of that in your patients?
Most of the time it's not a big problem, but it is a problem. And I have seen lots of dyspepsia related to it, and a few times some increased bleeding. The big worry is my patients with arrhythmias. They have AFib, or they've got a pacer in it or whatever, and they're on warfarin.
Yeah.
So warfarin patient, I don't give them Nsaids. For their pain, it displaces warfarin from the proteins that carry it.
Now, for those patients, do you typically use acetaminophen instead?
Yes. Yeah, that would be it.
Or an opioid even?
Well, I don't like to think about if it's... what I do in those cases, actually, yes, sometimes I'll temporize and get them on, say, Tylenol number 3 or something, but then I'll move them over to the hematologist and say, how do you want to handle this? This guy can't afford Xarelto.
I think sometimes we forget that we have an option to use topical Nsaids instead of oral Nsaids.
Yeah, and there are lots of topical Nsaids, and I'm not going to name trade names, but you can like diclofenac is one,
right?
And most of the pain management doctors in my area can prescribe topical anesthetic creams and lotions and whatnot that help out quite a bit.
You know, in a previous podcast, we discussed NSAID use in an older adult who had hypertension, and she had quite a bit of osteoarthritis that was very painful. When you have a patient like that, what specific steps would you take to monitor potential adverse effects of the NSAID?
Well, I generally will start out with making sure they don't have H. pylori, and I'll get a breath test. We have a lab in there that can do that for us, and then I will check their BU and creatinine, get the lights that we need to know about, monitor their blood pressures. I generally will get a dipstick urine just to see if something else is going on there. So that's kind of how I monitor that.
With an older adult, are you thinking of using specific NSAIDs because of the fact that they're an older adult? I think in this case, this patient was 75 years old. What I'm thinking of here is, for example, an NSAID that has a shorter half-life versus a longer half-life, like the Oxycam's Piroxicam, for example, has a very, very long half-life. Do you typically shy away from those that have longer half-lives?
Absolutely. I do. In fact, I don't think I even write for those in the older folks. I usually will stick with low-dose ibuprofen, lower dose, shorter duration of action. If they do have an adverse event, you can get them off of it real quick. Yeah.
What about in this circumstance, this older adult has hypertension? How would that factor into your clinical decision-making or follow-up with her because of the hypertension?
Well, I want to know what her GFR is. And,
great point.
We want to make sure that her kidneys can tolerate. If it's above about 35 or 40, I'm okay, I guess, with a short-acting NSAID, but even celecoxib at a lower dose, 100 milligrams, as long as you're watching it, it is okay. I have some patients on as much as 400 celecoxib for other conditions, and they do just fine.
Okay.
It doesn't affect their kidneys that much.
With respect to high blood pressure and the use of NSAIDs, have you seen blood pressure rise over the course of time in patients who are on NSAIDs?
I would say on average that it'll go up 1 or 2 or 3
So not
points.
too significant.
Not much.
Now, if a patient, though, has hypertension and you started an NSAID, at what point would you discontinue the NSAID because the blood pressure is getting too high?
Well, that's a great question. I think if their blood pressure, it's a combination of things. I would have to look at their GFR, their BU and creatinine. If those things are staying stable but their pressure is still going up, I'd probably just change their blood pressure medicine a little bit and keep them on the NSAID.
So like raise the blood pressure medication
Yeah,
dose?
I might change their metoprolol from 50 to 100, for
Okay.
instance, something
Okay.
like that. But I'd be careful with the ARBs or because they reduce renal supply already. So you don't necessarily want to put them on losartan if they're not on it, for instance, because it does, lower GFR initially. So it's a lot of things to think. You got to look at the whole patient. What else is going on with them? What are you treating?
Yeah.
How much is their quality of life affected? If their renal function is going down the tank real quick, then you got to get them off of it. But if their renal function's okay, but their blood pressure is still going up, it could be just that they have gained another 5 pounds, or they're not being compliant with limiting salt intake. You have to look at all of these things,
In that circumstance, would you consider rotating to a different NSAID?
If they're not getting good analgesia, yes.
Well, what if they're getting good analgesia, but the blood pressure is still increasing?
Well, I might consider moving them to a celecoxib, but not because it's renal protective, but just because it has a different mechanism of action, and it may not cause their blood pressure to go up. It may not have the cardiovascular effect.
I had some patients in whom this clinical situation occurs, and when I suggest rotating to a different NSAID, they're just absolutely antagonistic against that because they feel like they're getting such good relief with X particular NSAID that they do not want to risk quality of life improvement.
What I have to do in that case, say, this is a decision that you have to make with me. If your quality of life is good and your blood pressure is going up with that, if you can make some other commitments to change, I think we'll just leave you on that.
Yes.
It's a quality of life issue, and if it's an 80-year-old person and they need to be able to take that walk and play with their grandkids, and the only thing that's doing it is that particular NSAID, then it's an informed consent sort of situation.
You're right.
Yeah. So, and I document that in the records.
Absolutely. That's critical these days. Documentation. In podcast 2, we talked about a 48-year-old gentleman with chronic kidney disease, stage 1, so pretty minimal, but still there. And this patient was using an NSAID for chronic wrist pain. Acetaminophen failed. He couldn't use opioids because he had a history of alcoholism, so that was completely out. How in this patient or patients like him would you balance the risks and benefits of an NSAID?
Well, again, it's kind of like my other patient I was talking about. I would discuss with him what the reported side effects are, what the intended effect is, and what's happening to his kidneys.
Yeah.
And if he agrees to close monitoring, I would probably, if he's getting fairly good relief with that particular NSAID, I'd probably leave him on it. If not, then I'd probably consider switching him to another one, but keeping close watch on his renal function.
Yes, and how would you do that? So when you say close, is that every 3 months, would you monitor BUN creatinine, calculate GFR? Or how would you do that?
When I'm seeing him for the first time, I'm getting that right then. And then when I start him on a med, a particular Nsaid, I always have them come back in 1 month, and I recheck a basic chem and look at that. And if that's staying okay, then I will have him monitor his own blood pressure and see him in 3 months. And then I usually will monitor twice at 3 months and then twice a year, kind of close watch first if everything seems stable. But it's important that we develop a ease of communication with a patient that they can trust.
In this patient with chronic kidney disease, I think that a lot of practitioners, though, would shy away from prescribing NSAIDs for fear that the kidney disease would worsen.
Well, I think that's a rational and reasonable fear, but I think if you monitor it, you can lessen your own fear of it.
Right.
And it's certainly a lot safer than starting somebody on narco, for instance, or Vicodin or Percocet, because you don't have the risk of dependency, somnolence, all the respiratory depression,
right.
All the things that can happen with opioids don't happen with Nsaids.
That's right. This is a patient in whom the dose was increased as well of the particular NSAID to get a better effect. When you consider increasing the dose of an NSAID, what goes through your mind in terms of increased risk of side effects?
The first thing I worry about is stomach issues, gastric issues, and second is renal problems, and the third is there a change in the cardiovascular health? Is he noticing some palpitations, or as my patients typically say, why am I having all this ringing in my ears? And so when you start getting those kind of complaints, then going to have to back down or change Nsaids. And so we watch for that pretty closely. If you increase it, though, and they're getting better analgesia and less inflammation, their osteoarthritis is cooling down, their knees are feeling better, their hip pain's going away, and everything else is staying stable with their renal function and GI issues, and they're not having any bleeding anywhere or increased bruising, then I'm comfortable with that.
And finally, Blaine, what's your recommendation for using NSAIDs in patients who have chronic pain, or acute pain for that matter?
Well, I think it's our first step. I would use an NSAID for acute pain right away. And people who with chronic pain, depending on how it's defined these days, if they're getting good relief even months into their arthritis, it's a patient sometimes has to decide whether they're going to get a total hip, total knee, if they're going to get some surgical procedure to relieve their osteoarthritis versus staying on Nsaids and getting a fairly comfortable quality of life without the risk of major surgery, then let's do that.
Blaine, from the perspective of a physician assistant, how best can you and others counsel patients in pain who are using Nsaids?
I like to have a few minutes with a patient and explain to them the dangers of opioids. And I'll talk about respiratory depression with them. I'll talk about tolerance and dependency. And then I'll talk about, as my dentist does, the ibuprofen strength equals hydrocodone when it comes to these bony pains, these acute muscular issues. And of course, I do mention to them the risks. If you're getting stomach upset, you see some bleeding, and don't drink more than 2 mixed drinks a day.
Right.
I give them a little talk about alcohol and that. So every one of my patients, when I first start them on Nsaids or Tylenol, get that kind of talk.
True. So you're focusing on the benefits of the NSAID, certainly compared to opioids, as well as the potential side effects.
That's correct. I focus on how safe it is, what the risks are that are minimal compared to the dangers of prolonged use of even short-term use of opioids. Actually, let me just rephrase that slightly. If I'm starting somebody on Nsaids, and including Tylenol, I don't even discuss the possibility of using opioids. I just tell them that opioids are dangerous, and it's much better for us to keep you off of it, because I don't want them to start thinking about
Opioid use.
getting
Right.
some kind of opioid that will make them feel good.
Mm-hmm.
You know.
I think those are terrific recommendations.
Well, thank you.
In summary, we talked about the benefits and risks of NSAIDs in the average patient, as well as patients who might have hypertension and chronic kidney disease. Blaine, it was a pleasure having you here today. Thank you.
Thank you. The pleasure's all mine.
Thank you for listening to Over-the-Counter Analgesics: Who, What, Which, and How Much, a 4-part series featuring Paul Christo, MD. This program is supported by an educational grant from Pfizer. This has been a Dana Miller Video Network presentation.